but
Akshay,
inviting difficult questions.
good that he is inviting questions so that we can discuss more. But Akshay sir, he is absolutely right when he says, see, you know that the patient is your patient, you know he had a burst abdomen and which had healed by secondary intention. So between the first laparotomy and the incisional hernia, he never had a period of normalcy as far as abdominal wall is concerned. Right?
Yes.
So I think he is right in saying that once you already have a cause of the pathology, you may not ask any other because he already had an incisional hernia. Immediately on healing, there was an incisional hernia.
Yes, sir.
This is actually, for all the PGs who are coming in, a very important point. I think it is the latest edition of Bailey that has a very nice line. It says the incidence of inguinal and ventral hernias is no more higher in Olympic weightlifters than the general population. So by that fact itself, heavy weightlifting is not a risk factor for any form of herniation or worsening. And I think now that the books are having this sort of data incorporated within it, we should start omitting these lines from negative history because they are not contributory factors as far as what we understand today.
Yes, sir.
There are two things. If it is a graded, gradual weightlifting, which will, rather than weakening the wall, it strengthens the wall. And if it is inadvertent, accidental, non-weightlifter suddenly increases the weight or lifts the weights, that time the tissue tear occur, which can leads to that. So all generalized history, weightlifting history is absolutely not correct. What sir has told, that is very much correct. Second thing I would like to know that, is there patient is having any history of a weight loss, because he is having a since long bilious vomiting, not able to take anything more orally. So do you have even investigated for that?
Sir, in post-op period, patient was having
Post-op, pre-op, because he is having 6 months bilious vomiting.
No,
And
sir.
you have, in your history, you have said the patient has been operated for a laparotomy and resection anastomosis was done. So is there, what my question is related to the any tuberculosis part you have evaluated or not pre-operatively?
Sir, we have preoperatively checked cervical lymph node and inguinal lymph node, sir.
No history beta. Is there any history of weight
no
loss?
history of drug? No, sir. Patient was not any history of drug intake. Not taking it.
So
Doctor,
basically, sir wants to know how do you evaluate the history of weight loss?
host, please mute Sabha Rupani. Sabha, please mute yourself.
Sir,
Yes, sir. Good morning.
patient was not having history of weight loss.
Please mute yourself.
Okay, if there is no history of weight loss, forget about it. My question was that simple only.
Yeah.
Shall we go ahead?
Yeah.
Next slide.
Good morning, Apurva.
Good morning, sir.
I have a question. Actually, I think Rajan was trying to ask, because you had a record, so you know what the patient is having. But normal circumstances, you don't have a record. So was the patient operated for tuberculosis, do you think? Akshay?
Yes.
So the question, I think, Rajan, am I right or not?
Yes, sir. I would like to know, because he has given the in laparoscopy, he has told about the perforation. And now he is telling about the persistent bilious vomiting and resection anastomosis. So two different pathologies he logically thinks. So that will be very difficult in exam to answer.
So the point here is you cannot know what patient actually, unless patient has been given AKT for 9 months. Second pointer would have been a that first surgery, before that what the patient had. The complaint may suggest, but it will be very elaborative. I think you can omit that part and simply say patient was operated for something and there is no evidence of, you should say there was no evidence suggestive of in history that patient had a tuberculosis. Might be having, we don't know. Only evidence you can have is the patient had taken AKT after surgery or not. That's it. Please continue.
So when you are presenting a long case, try to evaluate the history as far as possible, but try to justify or try to narrate the history which is only significant to your case. Otherwise, this kind of a zigzag will going to happen.
Yes, sir.
Okay, go ahead.
Sir, no significant past history or any drug history, no significant family history, and no addiction.
I have a question here. The past history, when you take from the patient with respect to incisional hernias, what are the points which history would be more relevant here, apart from the surgical history?
If patient was any taking drug for a long time, or
would the history of COPD have any significance in incisional hernia patient?
yes, sir. If a patient is having COPD, then due to repeated coughing, there might be increased abdominal pressure, which aggravates the incisional.
So basically, you get more complex hernias when you have COPD.
Yes.
Anything else?
Dr. Tanwani, we're getting a lot of noise from your side. Can you please mute yourself?
Host, please mute Dr. Rahul Tanwani.
No, sir.
Yeah, continue. Dr. Khandelwal, please continue. Sorry for the disturbance.
Would you be interested in knowing about the diabetes and its implication on your incisional hernia repair?
Yes, sir. If patient is diabetic, then more chance of infection post-op, sir. So it might lead to SSI and can lead to burst abdomen.
Fine. I think you can continue. Yeah.
Summary: a 40-year male patient with swelling in abdomen since 10 months, which is completely reducible, and dilating pain since 4 months. Patient operated for laparoscopic peritoneal lavage and drain placement, and then exploratory laparotomy, resection of bowel and anastomosis, and then developed burst abdomen, which healed by secondary intention. On general examination, patient is well built and well nourished, weight 92 kg, height 168 centimeter, and body.
Akshay, wait, go back. Go back. What do you mean by swelling in abdomen?
Swelling over abdomen.
So what is difference? So this is the only summary you have in a history part. So this is summary of how hernia developed. But ODP includes up to 2 days. So what else you should add in history in summary? Well, how does that hernia behave? Does patient complain of swelling increasing after cupping, decreasing, impulse? What about that in summary?
Yes, sir.
So you mentioned about only how hernia has developed, but how hernia behaved? It is not part of summary. From this, you can show patient had a burst abdomen. That's what I could understand. Where is the hernia part? So hernia, this is not the only summary of history, also include patient's complaint. Yes. So patient had come with complaint only swelling. What else patient had? What do you mean by completely reducible?
The swelling reduces on lying down completely.
Yes. So have you written that? It disappears on lying and completely. Okay. So you should give more importance to the hernia part itself. It includes, this is okay. How it has developed, we all understand. The summary part, what is important, what is present scenario. Because we are going to treat the patient on summary part. That means of a history of present illness. Fine, for a delineation you have said that's fine, but you should give more importance to hernia itself. The skin, does patient complaining anything about skin of swelling or that? Does patient have any complaint or not?
No, sir.
When the thinning of skin occurred, patient is not aware of thinning of skin? Did patient complain when did the thinning occur?
The patient is not.
We'll discuss when after examination, but okay, continue, please.
The patient is well built and well nourished, weight of 92 kg, height 168 centimeter, BMI 32 kg per meter square, temperature normal, pulse rate 80 per minute in right radial artery, blood pressure 130 by 80 millimeter of mercury, respirated 15 per minute, abdominothoracic breathing, no pallor, edema or overfit. Per abdomen examination, I have examined patient in adequate light after taking due consent in standing and supine position. The abdomen is flat in supine position. Midline scar present 7 cm below the xiphisternum and 4 cm above the pubic symphysis. Scar is stretched out and skin over it is thin. It is discolored, hyperpigmented, no ulcer or erythema over skin. Umbilicus displayed to right side of midline. No sinus or fistula over anterior abdominal wall. Cuff impulse present. 3 scar of drain side present, one on right lumbar region, one on left lumbar region, and another on left hypochondrium, but no cuff impulse present at drain side. On straight leg raising test, swelling gets more prominent and increases in size up to 20 by 15 centimeter. On standing, there is swelling or anti-abdominal.
Sorry, Akshay, stopping you in between. By looking at the...
Yes.
Hello, Akshay, sorry to interrupt in between. But by looking at the slide, I understood the question of PRM, sir. Didn't the patient have any complaint regarding the change in the skin color? So that's why it's important, sir, what sir was asking you.
Yes, sir.
Right. You should include, even if the patient had not complained, you should understand that this question will come, that there is change in the color of the skin over the swelling.
Yes, sir.
So what I think that even if by any chance the patient does not complain, you try to evaluate this history.
Yes, sir.
By directly asking and include that in your chief complaint and also in the ODP. That's why the Modi sir was asking you whether there is any change, whether the patient complained any change in the color of the skin or not, right?
Yes.
This is unmistakable change in the color. So obviously patient would have complained, right? So you can continue.
Yes. On standing, there is swelling of anterior abdomen of 20 by 15 centimeters. Swelling completely reduces on lying down. Visible peristalsis seen under the scars. Other hernial sites are normal. Extragenitals are normal, sir. On palpation in supine position, temperature normal. Abdomen is soft, non-tender. And on straight leg raising test, swelling increases of 20 by 15 centimeters. Skin overlying swelling is pinchable. No palpable organomegaly. Expansile cuff impulse is present. And defect size palpable of 12 by 10 centimeter. And in standing position, swelling is soft and non-tender.
What do you mean by skin is pinchable?
What
is your interpretation?
Skin is not adherent to underlying any bowels.
Okay, you want to say it was not adherent to the content rather than a swelling itself.
Yes, sir.
But ideally skin pinching is possible and there is no content that should be specifically narrated rather than, because sac is a part of or swelling. So when it is prominent, at that time you must have to consider that this is a swelling itself. So sac is part of a swelling.
Yes,
right?
Sir. Yes, sir.
That thing you should keep in mind. And I think your history or size of a swelling is very small, you have mentioned, if I am correct. 4 by 3 centimeter you have mentioned, I think so.
So initially, sir, when swelling developed at that time, then it
now my question is, if there is a burst abdomen, so you want to say that there was a localized burst abdomen, then it become full-fledged later on? and then the hernia develops?
Sir, entire length of incision was not burst, sir. Only proximal part of incision burst.
So at present, how it will reach to the 15 by 15 centimeter, 15 by 20 centimeter? Now you are describing 15 by 20 centimeter size of a swelling. History says 3 by 4 centimeter size of a swelling, and you are giving the history of a burst abdomen. So these are the findings which are not correlated with each other. Either your history is a problem or your present scenario is problematic. But I think present scenario is correct on examination. So your history might have some garbage.
Yes, sir.
Continue. Complete the your examination. You have completed.
So on percussion, tympanic knot or swelling is there. Auscultation, normal bowels out, and digital parietal examination is normal. Cardiovascular, respiratory system, and central nervous system normal. So summary: 40-year male patient with a reducible swelling in abdomen since 10 months and dull lacking pain since 4 months. Twice operated, first for peritoneal lavage and drain placement, and second for exploratory laparotomy with resection of bowel and anastomosis, and developed burst abdomen and healed by secondary intention. On examination, patient is well built, single swelling of 20 by 15 centimeter, which appears on standing and completely reduces on lying down. So scar is stretched out and overlying skin is thin. Visible peristalsis seen, defect size of 12 by 10 centimeter.
Start with the first slide. Khandelwal Sahib, Aham.
What is the importance of BMI in this type of patient?
Sir, if a patient is poorly built or not nourished, first we should improve his nutrition before operating for incisional hernia. And it also suggests that patient might have any chronic condition like tuberculosis.
What is the more relevant finding, undernutrition or overnutrition in incisional hernia patients?
Is it undernutrition or obesity? That is his question.
See, most commonly, these are patients that are leaning towards higher BMIs, right? Like your patient also has a BMI of 32, another 0.5, and you would be considered obese by Indian standards. So if you have obesity, it sets up a vicious cycle in incisional hernia particularly, because obesity is one of the risk factors for incisional herniation and an increase in size of these hernias over a period of time. Not just that, these obese patients have usually some other comorbidities like arthritis that reduces their exercise tolerance, maybe having cardiovascular issues that causes them to keep gaining weight. What's worse is an incisional hernia by itself causes paraspinal muscle spasm, and that discomfort also disallows these patients from going out and exercising that much more. So the hernia also keeps getting worsened and they keep gaining more weight also as a result of that. Your implication as far as surgical planning is not so much of helping the patients gain weight in undernutrition. Most commonly, it is how to convince obese patients to lose weight by at least a couple of BMI points, be eligible for a hernia repair, because morbid obesity is one of the modifiable risk factors for recurrence in these cases.
Yes, sir.
I'll just give you an example, Akshay. Yesterday, we operated a patient of incisional umbilical hernia, which we had done around 12 years back. We had done a laparoscopic cholecystectomy, and the patient already had an umbilical hernia at that time, which was repaired, and the patient had no complaints for 10 years. After that, she developed hypothyroidism and she gained a lot of weight. And in the last 2 years, she developed the incisional hernia. So obesity is definitely a very important point.
Yes, sir.
So can you tell me what are the levels of BMI when you start getting really concerned and you won't operate on the patient without weight reduction?
Sir, if a BMI is more than 40, or if a BMI is between 35 to 40 with comorbidities like diabetes, then we should do weight reduction.
What I mean to ask you is whether it is a BMI more than 30 with a higher complication rate or a BMI more than 35 with a higher complication rate. So when does the complication rate go significantly higher?
I don't know.
Fine. Now, so when you have BMIs above 35, you have a more than 50% chance of hernia recurrences occurring. And not only that, you have a significant increase in the complications following surgery, right from seroma to hematoma to infections. So above 35 BMI, it's always advisable that the patient undergoes a weight reduction procedure before the surgery is to be planned. Now,
yes,
the other point is if I have a BMI which is between 30 and 35, now you wouldn't be advising the patient surgery. But the problem is asking patients to go and reduce weight is a very, very difficult scenario in actual life. Most of the patients would not be able to reduce their weight, and we end up operating these patients with a higher BMI. But then they have to be made to understand that they are looking at a higher recurrence and complications. So it helps you in counseling the patients preoperatively about the implications of the surgery.
yes, sir.
In the social history or the personal history, would you give any significance if the patient is a smoker?
Yes, sir. If a patient is a smoker, then because of nicotine, there will be vasoconstriction and wound healing will be poor, sir.
Anything else apart from that?
So chronic smoking led to COPD, which might also increase risk for hernia.
Well, basically, smoking even without COPD increases the hernia risk of recurrence. So smoking itself is an indicator that the patient will have a higher risk of recurrence. And so patients have to be counseled. And over and above that, there is a higher risk of your perioperative complications, right from your respiratory complications to the wound infection problems. Okay.
Yes, sir.
Next slide. Okay, keep it. Rajan bhai,
within the slide, you mentioned that the lateral scars, are all drain sites. But I think in a patient who's undergone a lap procedure previously, a lot of these may be port sites as well, right? So what is your main concern with having so many incisions on the abdomen?
Sir, I didn't get the question. Sorry, sir.
No, so you mentioned, while you were narrating the examination findings that the patient has lateral scars as drain sites. I don't think all of them are going to be drain sites. Some of them will be port sites as well. So you restrict your discussion to only number of scars and their relevant sizes. Now, when you see a patient with this sort of a midline hernia with several scars away from the hernia site, what is your concern or why is it relevant for you?
So because at other sites also there might be cuff impulse present and we have to tackle it during the surgery.
All right. So you're thinking about multiple defects further away.
Yes, sir.
Right. Drain side hernias we have not seen, but laparoscopic port side hernias are very common. So what sir is trying to say is that whenever the patient has a history of laparoscopy, you have to differentiate the laparoscopic port sites and the drain sites.
Yes, sir.
And you should pay more attention to the port side.
Yes, sir.
And also you can, and if possible,
Hello.
Yes, sir.
Something happened. He was asking a question.
part was a drain side and other were the port sides.
Sorry, we didn't get your question.
Hemant sir, you got muted in the middle.
Okay, sorry. No. There was not a question. I was.
Okay. I think
he is having
Achi network maybe.
Rajan bhai sahab, tomare ke?
No, no, okay.
Left lower scar is of the drain, or the right lower scar is of the drain, and other scars are of the ports.
Yes.
That you can very well say in your findings.
Yes, sir.
Akshay, looking at this patient with a stretched scar like this, does it give you any indication of what type of repair you should be performing?
I would like to do retrorectus mesh plastic.
Open, lap, robotic?
I would like to do open.
Okay, what is your justification for that in this patient?
The skin is thin.
Okay. So it gives you an opportunity for scar revision, one
Yes.
thing. The quality of the skin in the midline is not that great, but anything from the patient's past surgical history that is, making you lean more towards open?
The patient is mild obese, so laparoscopy can be done. But sir,
This patient, how will
No,
you do
sir is
laparoscopy? In this patient, is there anything in past history that is urging you towards going in?
Akshay, sir is asking about previous history.
Previously operated for laparoscopy.
No, see, Akshay, patient has had more than one violation in the past. They've had a burst abdomen. These guys typically have a burst abdomen for two reasons. One is a technical issue at the time of closure, and two is a missed pathology or an intraperitoneal collection at that time, which is expanding. As a result of which, normally you'll end up having dense visceral or parietal adhesions in these guys. You may try to do it hybrid or completely laparoscopically, but it will be extremely challenging, a long procedure with a higher risk of enterotomy. You also don't know what the primary pathology in this patient was. Everybody kept going back saying bilious vomiting, had a perf that was missed. There are so many different variables. So in your patient, an open procedure is more likely to be successful and robust, even though it has a slightly higher risk of SSI as compared to a laparoscopic procedure.
Yes, I am very well said. I would like to add, you have already said skin is thinned out and visible peristalsis. So there might be a bad adhesion between scar and the intestine. It will be very, very tough to deal that laparoscopically, because as soon as you do create a new peritoneum, it will pull out. So it is very difficult. Obesity has nothing to do with it. It is mild obese, so we'll do laparoscopy. That is recognized. It has nothing to do with that. But the previous surgery yourself said lavage was given, so there was a history of peritonitis, as I have said. So understand that point of view. It will be very difficult to create. Secondly, the scar revision will anyway require. Pure laparoscopy is not possible in this case. So it has to be either hybrid or open. So yes, your answer should be open. That's what I believe. It's okay what I said.
Absolutely, sir.
And my opinion is it should be done open only without hybrid even attempted, because previous surgery laparoscopy there is a plenty of pus. What is the history? There may be adhesion. Post laparotomy again there was a resection anastomosis, plenty of adhesion. So one should avoid doing any venture into it in a form of a laparoscopy or a hybrid. Straightforwardly go, revise the scar, put a mesh, better result.
Yes.
Discussion will be what incision is to be put rather.
Yeah.
That will come to when we'll come to
yes.
Right? So where is umbilicus? Is the umbilicus seen? You said displays on right side. Do you see
sir.
umbilicus?
Sir, here on this thing there is umbilicus.
So it's the more of a upper abdominal or lower abdominal? Do you say it is it likely to be umbilicus? How far away from xiphisternum it is? What is the distance between xiphisternum, umbilicus and symphysis? Why it has happened?
Sir, it burst abdomen, it healed by secondary intention, so there may be displacement of umbilicus.
Was a graft put or it healed by secondary intention?
No, sir, graft not put. Patient is giving history of regular cleaning and dressing for 3 to 4 months, sir.
Okay.
So why my question is why the burst abdomen closure was not planned? Do you have any history for that?
No, sir. At that time, there was in burst abdomen, pus was still coming. So closer revision secondary closure was not done.
Akshay,
That
your
all-
answer should be, I don't know.
And
Because
second
you
thing,
try to answer it because patient is yours. But it
Yeah.
should, you do not fall in that trap. Your answer will be, sir, I don't know why it was not done. You understand? Because
Yes.
patient is never going to answer you that why it was not done.
Yes, sir.
So you can be in trouble from where the pus was coming, why pus was not dead. So the answer should be, it was, I don't know. That would be the best answer. Everything doesn't have a reason, right?
Yes, sir.
Please, Rajan bhai, any other question?
no, sir.
No.
We go for a management part.
Yeah,
Already
yeah.
management
Palpation. Because
comments
there
are
are-
already done.
Let us
Khandelwal,
have a
sir.
palpation. Next slide.
Dr. Khandelwal, Aham, do you have anything?
No, nothing, sir, at the moment.
Yeah, me neither.
Yeah.
Keep the video on for a second. Okay, thank you.
Okay. Go back to slide of palpation. Yeah. Okay. Yes. Anybody would like to ask anything?
No.
Okay. I have a one or two question. You write down the skin over like the swelling is pinchable. What does it mean?
Sir, skin is not adherent to underlying set or content.
Yeah, you know that that's the reason, but it is possible. So what does it mean?
Why?
How does it help you?
Sir, while putting the incision, we should be careful while dissecting the set if a skin is not pinchable.
Okay. So can you preserve? Do you think this you can preserve this skin?
Sir, if a skin is adherent to, if
No,
set,
this patient, you have said it is not adherent. Okay, let us discuss in management, but keep this question in mind. Yes, sir. Please
so
continue.
Akshay, what sir is interested that you should also be mentioning whether the thickness of the skin is same as the normal skin or not, or the skin is thinned out.
That is the most important thing. See,
Right,
it is
sir.
absolutely thinned out.
Right. That is what Modi sir is trying to hint you that point is also important, or rather more important, that skin texture of the skin and the thickness of the skin.
Thickness is very important. Yeah. Thinned out is that. Right? Okay. You said on straight leg raising test, swelling is of 20 by 15 size. That's the only information you will give when you do straight leg raising test. Would you like to add anything?
Muscle can also be, sir, if they are atrophied or can be palpated.
Second point is that 20 by 15 means 20 vertical or 20 horizontal?
Sir, 20 is horizontal more than.
Okay. So, and according to your SLR, it is a single that you have mentioned, that it is only a single defect, or do you palpate in more than one defect?
A single defect, sir.
So you should also write down there is a large single defect, right? There are no other. What about lateral to the swelling?
That is the most important. Apart from the swelling, what you need to see is the rectus. Where will you find that? Will give you an idea of what type of repair and how much repair you can do.
Yes, sir.
And second thing is, when you are palpating a defect, you mentioned 10 centimeter by 12 centimeter palpable defect, which is in the normal resting abdomen, or does SLR will reduce the size? That is also important to know the strength of a rectus.
Yes, sir.
Whether it is able to approximate the rectus or a sheath, that is also you can know from the SLR.
Okay. Akshay, another question. You said swelling size is 20 by 15, right?
Yes.
So is it 20 horizontal or vertical?
Sir,
Normally, when you say 20, is it 20? I believe vertical, but I think it is 20 is horizontal.
Yes, horizontal 20.
So you should mention why it is horizontal 20 by 15 and defect is 12 by 10. What do you get from that?
Sir, gapping between the two rectus muscle is...
That is fine. You said size swelling is 20 by 15 and defect by 12 by 10. What does it mean? And how does it help in your management?
Sir, transverse incision or vertical incision. If
one is incision, what else? More important is
mushrooming.
What do you call this swelling? Why it is 12, 20 by 15 when you do SLR? Mushrooming. So what is mushrooming?
In mushrooming, the defect will be small, but the sac will be more wide.
So you can call it spillover. It is called a spillover. So actually, the sac has come lateral from midline on all the side. Do you understand? That is the point. So what is significance of that?
So we should, during surgery, we should do lateral to medial dissection so we can preserve the seat as much as possible.
Okay. And other thing is, this is probably case where the transverse incision would be better. That we'll discuss. But that is another point. That's why very important to say which 20 by 15, which is 20 and which is by 15. Right?
Yes.
Next slide. Why did you say in standing position? Go back. Only one thing you have mentioned in standing position. Swelling is soft and non-tender. What is that? Huh? What is significance of that? In standing position, what do you say?
In standing position, swelling is present. Swelling is...
Obviously, swelling is present. But why did you say now in standing was soft and non-tender at that time? Any significance of that? You shouldn't mean. It is obviously it is like that, right? What do you see in standing position? That is the important point.
And normally, when you are mentioning the size of the swelling, in case of the hernia, size of the swelling in the standing is automatically reflect it is normal presence of a swelling, which you have mentioned in the supine with the SLR. That is an additional measurement, right? So normally, ideally speaking, you should mention in hernia size of a swelling and extent of a swelling usually in standing position. So that at that place you should have mentioned. That's what sir want to tell.
Yes.
Go ahead.
Okay, fine. I think we can go to the investigation part.
Yeah. What investigation you would like to do?
Sir, I would like to do pulmonary function test, routine blood investigation, serum protein albumin, and CCT abdomen pelvis.
Why serum protein?
Akshay, pulmonary function test should come last. See, it should not be at least on the top of the list. Then you are going to have a lot of problems.
Yeah, you are Akshay.
Yes, sir.
Sorry. Akshay, usually speak whatever you are doing in your wards. In your exam, speak the examination in the chronological order in what you are doing in your wards. Do you do PFT and CT first?
No, sir.
Or you do the sonography first?
USG first, then CT.
So please try to remember USG? Whatever you are doing. Yeah, whatever you are.
Yeah, Hemant, please continue.
Hello. Hemant, you are muted.
Hello.
Either Hemant is having a connection issue or he is repeatedly getting muted.
Akshay, can you play the CT again? So what is the information that you're getting from the CT?
Sir, first from content of the sac. Sir, bowels and mesentery are the content of the sac. Then width of
Which bowel?
Sir, it is a small bowel or a large bowel. And
it is primarily the transverse colon which is going in.
yes.
Yeah.
And the upper part
Right.
and lower down, there is small bowel. Can you have any sort of a comment as to what type of surgery this guy has undergone in the past based on CT? Is that relevant?
Akshay,
Yes.
if a question is asked, either answer it or say, I don't know, sir.
I don't know, sir. I don't know, sir.
The transverse colon seems to be in normal position. If you just scrub ahead a little bit, don't press play. When you move your cursor over the video, there'll be a
Yes.
scrub bar that comes. So you don't press play, go to the right.
Yeah.
Yeah, so you can see the transverse colon is in its normal position, but you're not able to appreciate colon on the right upper quadrant properly. And there's a lot of conglomerated small bowel loops in that area
Yes, yes.
that come in. So possibly something to do with the right side of the colon. The other problem that the patient has, you want to make any comment? Let me give you an opportunity based on what you're seeing on screen right now.
Sir, bowel loops are clumped, so there might be
Yeah.
interconvolution. Then the rectus muscle thickness and the distance between rectus muscle and lateral abdominal muscles, they are external oblique, internal oblique, and transverse abdominis are not thinned out, sir. They are well.
Yeah. So is that a good thing for your hernia repair or a bad thing for your hernia repair?
Good thing.
Actually, it works in a counterintuitive fashion. Male patients with thick muscles land up becoming a very big problem to close when you take the patient up for surgery, even with component separation sometimes. Which is why I see a lot of times to facilitate closure, we'll end up using something like Botox, right, in the preoperative period.
Yes, sir.
So the classical, now these are certain things that you have to just eyeball. You look at a scan, you're not able to have a gut instinct as to whether it's going to come together easily or under tension with a lot of force. Classically, it is middle-aged female patients that are slightly on the obese side, that are multiparous, that have very easy closure. Male patients, on the other hand, are particularly problematic. So if you scrub back a little bit, you'll see the rectus muscles are very, very thick. They are quite wide.
Bulky and lateral.
The external oblique is particularly very, very bulky. The defect seems to be at least 15 centimeters wide at this point. So this is a challenging case.
Can you put the cursor on the rectus muscle?
Yes, sir.
CT, Akshay?
Yes, sir.
No, don't move. That was an excellent.
Yeah.
Yes, see.
So very wide, how do you
Displaced
say?
rectus.
Yeah, displaced rectus right now. So this is a challenging case here. He's also having irregular luminal cross sections within the small bowel. Now, you're given the patient oral contrast. That's another thing you need to look out for. The dilatation is way too asymmetrical, then this patient will require even visceral adhesiolysis. Otherwise, if there is no, what do you say, history of bowel obstruction, you can let go of these adhesions quite a lot of times.
Yes.
But I think if you are doing an open repair, the obstruction will definitely come in between.
Yeah, quite likely. What is another thing that you plan looking at the CT scan, the first step of surgery? How would you go about it, Akshay? Now you can see bowel is really badly stuck up there. There's transverse colon in the upper part of the hernia sac.
Even sigmoid colon in the lower part.
Yeah, so how would you want to plan your case now?
I would like to put transverse incision in open surgery. Then while dissecting the sac, I'll be careful while dissecting the sac, and while opening the sac also, so I will open from the neck region. And
Akshay, before we talk about the incision, can you tell what type of repair are you planning here?
sir, retrorectus mesh plasty with bilateral transverse abdominis release.
So do you think, Akshay?
Yes, sir.
Do you think that this rectus, which is displaced more than 10 to 12 centimeter from the midline, I think it is more than 15 also possible, right?
Yes, sir.
It is possible to bring together in the midline to put a mesh. You got my question?
Yes, yes, sir.
Huh.
Sir, if required, then replacement mesh plastic can also be done.
Where you will replace the mesh? What do I do not understand? What is your
Sir,
answer? Replacement mesh plastic. I don't understand.
sir, if the entire sheet, we are not able to close the entire sheet, then we'll put a mesh in
No, no,
between the
no.
two guys and relay
I
mesh.
think we have a problem in closing the posterior sheath also. That's what I think.
So then
Others
we can
may.
use the part of the sac as a posterior sheet.
Yes, that is the possibility, and that one can do rather than exclusively mobilizing the posterior rectus sheath. You utilize the part of a sac for a posterior abdominal closure.
Yes, sir.
Right. So when you are operating, the first thing you do is you don't excise the sac.
Yes, sir.
Right. You
Never.
start at one end. You start at one end so that and reach the rectus muscle on one end. Right. And then you can do whatever. I mean, as Aham sir said, you can go for a mobilization, everything, but you may require the closure may be difficult. So in that case, you can use the sac as a wall of peritoneum or maybe posterior sheath, put a mesh over there and then put another mesh on the top of it. Anyway, we are going for the investigations. Aham sir, Dr. Khandelwal.
Akshay, you said you wanted to plan a transverse incision. I didn't quite understand the reasoning behind that.
Sir, because the sac is more horizontal, length of the sac is more wider than length, sir.
But then how will you start? You wanted to do a TAR, right? If required. So
Yes,
the
sir.
TAR, we usually start much higher up in the abdomen. Through a transverse incision, how will you be able to reach the epigastrium?
So, if so flaps can be raised till the pubic
Not
line.
really.
Your incision has to be from one end of the abdomen to the other end transversely around the umbilicus, almost up from both the ASIS. But I think in a way he is right. Sir is right that you cannot reach up to the epigastrium. It is difficult. I think this was at the umbilicus or supraumbilical. The defect was supraumbilical, right?
Yeah, just about.
And seeing his SLR, rectus is displaced from, I think, from sternum to the pelvis. Pubic symphysis, the rectus is displaced. Whatever the scar or incision is there, or whatever, but the displacement of the rectus is seen from the epigastrium to the pelvis. So vertical incision, I think, will be the more better option. What you say, Aham?
I agree with that, sir. The other advantage that will happen is there is a little bit of a virgin area in the epigastrium, very far away from the transverse colon and the small bowel loops. It is a safe point of entry into the abdomen. If you try to take a transverse incision on the hernia, there is a significant probability that you'll suddenly be looking at mucosa because you're entering the fundus. So that is a little bit of a challenge. I think difficult case, high risk of recurrence, makes sense to be comfortable yourself at the time of surgery. A long midline laparotomy starting far away from the hernia would be a good strategy going ahead.
Yes,
definitely. Point well taken. Can you replay the video again, CT, because there it starts right at the epigastrium, right? Immediately below liver, it is there. So right from the huge one.
Yeah.
Does the patient have sleeping dyspnea or orthostatic dyspnea or something?
No, sir.
Because when we see the CT see on seeing the exam on the patient clinically, it appears to be a simple repair, but when you see the CT, I think if you close, the patient may even end up having compartment syndrome. But because the patient is lying down without any issues, I think a repair should not be much of a problem.
Yeah. In these patients, on resting, the swelling is not appearing. So I think there is no much more intra-abdominal tension is there. So quite possible that we can close it without any more problem. That's what I feel.
Yes, sir.
The abdomen has enough space to accommodate the bowel.
Dr. Khandelwal?
I do agree that transverse incision would not be a feasible option. In this type of a scenario, midline incision will be required because we need to dissect high up, doing a TAR right up to the central tendon of the diaphragm, and that would not be feasible by a transverse incision.
Yes, sir.
What sort of intraoperative parameter will you keep asking your anesthetist about during closure of the patient?
Closure, yes. That's very important.
I'd like to ask for end expiratory volume. While closing.
Yeah, should go on.
Sir, and expiratory volume.
Volume? Are you sure?
Pressure, sir. And expiratory.
Acha. So any sort of guidelines regarding this? What is the practice in your hospital? Nothing is set in stone, so you can just share what happens in your unit.
While closing, if pressure increases by more than 4 to 5, then mmHg, then we will keep a patient intubated for one elective intubation for 1 to 2 days. And
for how long?
Sir, 1 to 2 days, sir.
All right, fair enough. I would add something on top. You keep the patient mechanically ventilated in a sedated as well as paralyzed state. If you only sedate the patient and do not give enough paralyzing agents, then the patient starts getting abdominal compartment nonetheless, and it defeats the purpose.
Yes, sir.
Do you know of any possibility of delayed abdominal compartment in these patients, that they're okay for 1 to 2 days and they suddenly have problems?
Sir, I have not seen, sir.
Okay, so that is another possibility where patients, they have a change in pulmonary plateau pressures where about 4 to 5, you take a chance, you extubate these guys, they do well for a day or two, you put them on ERAS, and around day 3, they start manifesting features of paralytic ileus. So rather than paralytic ileus causing bowel issues, that causes the diaphragm to rise up significantly and they start developing type 2 respiratory failure. The treatment for them is again the same. You sedate, you paralyze them for a day, day and a half. You wait for bowel function to come back. You correct any dyselectrolytemia that may be there. You can even try a short trial of neostigmine in these guys to overcome the bowel issues. That is obviously done along with the anesthetist, and usually they resolve. So delayed respiratory failure is actually a sign of abdominal hypertension in these guys that sets in even before renal dysfunction.
Right. Yeah. So the previously we were not very keen on such, but now we elective intubation and keep patient on ventilator with paralyzed state is now practically norm in a large hernias like that. How do you monitor them while they are intubated?
Sir, we measure intra-abdominal pressure by catheter with catheter in situ. We measure intra-abdominal pressure through PUC. Sir.
How do you measure?
Sir, first we inflate the inject the saline 25 ml, and then at the heart level we connect full pint, sir. Then it raised. If the then we measure the column movement raised, and if it is then we compare daily.
No, we measure, like, connect with what?
The first with
which catheter you are talking about? Let me know which catheter.
Per urethral
the safe catheter is not enough word. You should hear as if we don't know anything. Catheter, which catheter? Per urethral. So you measure per urethral intra-abdominal pressure. How sensitive it is?
I don't know.
Okay. Which are the other methods? What do you do? Do you measure intra-abdominal pressure regularly in such patients?
Honestly, no, sir. We check the response that the patient is having on vent and then we decide.
So we have made a habit that we always put up PUC and manometry. Along with that, we measure that CVP measurement and measure the intra-abdominal pressure in all such patients. What is the normal pressure?
Normal pressure is less than 12 millimeter.
Yes, 12 or less is a normal. And so it is a rough, it is not very sensitive, but it does work in most of the cases. So at the end of 48 hours, we off the ventilator and still check that whether the patient intra-abdominal pressure is what is that, and then we extubate the patient. That is the need, or usually what we do apart from other parameters, and that helps.
Yes, yes.
Please continue.
So, looking at the CT, what are the things that you look for? Akshay, I think CT is probably one of the most sensitive investigation when we talk about incisional hernia, right? And I think Aham can put out very, very good salient points. But I think first of all, you try.
So first, the content of the sac, whether there can be interbowel adhesion, then the rectus muscle distance and width of rectus muscle, and then sir lateral abdominal wall muscles, external oblique, internal oblique, and transverse abdominis.
Dr. Arora, any
background music? What is of noise? What is that? I don't know.
Sahab, ખ્યાલ નથી આવતો ક્યાંકથી. I am also trying to see, પણ નથી ખ્યાલ આવતો.
I think somebody is unmuted. Okay, continue, please.
Aham, can you give salient features of looking for the CT?
So first and foremost, Akshay, a plain scan usually suffices in most of these cases. But if the patient has an old history of infection or has previously undergone any surgery for malignancy, then you have to shoot a scan with IV contrast. The decision of oral contrast is on a case-by-case basis. If there is a prior history of obstruction or current history, a patient is having recurrent subacute problems, then you should definitely put oral contrast in these patients, a slightly more dilute contrast than what is on screen right now, because that by itself can cause artifacts. The most important thing that you can take away is the defect size, the defect location, and whether there are multiple defects. Now, to give you a small example, a lot of these moderate size hernias will be taken care of by a Reeve-Stopa type of surgery. But say you have a drain site hernia or a port site hernia that is far away, that may be subclinical, palpation pe nahi samajh mein aa raha tha. You can diagnose them on CT scan and then possibly add a TAR in that area to ensure that your mesh coverage is extending to that point. So you should not have any missed defects. The other thing you want to know is what exactly is herniating across. And omentum is going to be treated with a lot more, boldness than large bowel or small bowel within the hernia sac. As I mentioned earlier, it also helps you plan where to start your incision. Now, this patient does not have a full-length hernia, but sometimes there are patients that have full-length hernias and you don't know kahan se kya kare. They are loss of domain cases. They are not reducible. So you look at the CT scan, you figure out where it is that the omentum is present maximally, and you make a small incision 2 to 3 inches long in that area to gain entry into the peritoneal cavity and then proceed with acidolysis. Beyond that, there are a few things like volumetry that you can ascertain whether the patient is going to need component separation or no. There is also something called Carbonell's index, where if the width of the hernia sac is, rather the hernia defect, is exceeding the sum of the rectus widths, then this patient will not be managed by a Reeve-Stopa, but you're going to need either an anterior or posterior component separation on top of that. You also want to look for previous meshes, because if somebody has put a mesh in, that means more adhesions, greater, more challenging case. Every recurrent hernia has a higher risk of failure, and you need to account for those factors when planning your repair. To give you an example, if you see a patient with an IPOM mesh and tax, don't plan for another IPOM. It's going to have a high chance of failure. If you're seeing that there is evidence a patient has a sublay mesh, don't do sublay again. Onlay, so don't do onlay again. Lot of different variables that you need to look for. Then, there are certain things that you have gut feelings for, like in this particular patient I mentioned, it may be a little difficult to close given how thick the lateral muscles are and how thick the rectus is looking. There is no absolute value for these thicknesses that I mentioned beyond which you'll have a problem. This is just when you keep seeing scans, you develop a sixth sense for. But this is all information that is not available to you in a clinical exam. In fact, the clinical examination for hernias is now, without a shadow of a doubt, found to be woefully inefficient. So when you are asked tough questions for an incisional hernia case in your MS or DNB exams, you are within your rights to say that on the basis of clinical examination, I feel this may be the best path forward, but a lot of the planning will depend upon the final imaging. You are within your right to say so. Because CTs offer a lot of information that clinical exam does not give you, which is particularly true for irreducible hernias, because you just don't know what the content is, you don't know what's happening with the scar beyond that. You on clinical exam can't plan these cases. Now see, this patient appeared to have a pretty benign looking hernia on the videos that you shared, but then there is transverse colon within 1 centimeter on entering.
Yes, sir.
So based on the scan, I would have said, transverse incision nahi chal sakta. But based on clinical exam, I would have said maybe you may be able to get away with it, right? So imaging is extremely important in these cases.
Yes, sir.
So what else do you get in CT? Have you got that marked CT you have shown?
Yes, sir.
This is what? Explain a little more.
Sir,
what is Tanaka's India and what is that? So for the benefit of the students, what did you understand by that? And how does it help in your management?
Tanaka index is ratio of volume of the sac and volume of the abdominal cavity. If it is more than 25, then bilateral transverse abdominis release is necessary. Carbonal index is distance between the two recti, ratio of sum of width of the rectus divided by ratio between the distance between the two rectus. And
so how does that Tanaka index works? So that is why clinically is insufficient, as the Aham is saying. The point here is that if the Tanaka index suggests there is a loss of domain, that means there is no doubt about putting that patient on definite ventilation immediate, because you do not extubate those patients, because it is a very simple thing that the area within abdomen is not sufficient to accommodate the outside hernia which is there. Do you think in this patient it will be a problem?
No, sir.
Why?
Because swelling is completely reducible on lying down. There is no.
So any lying down position, it is staying inside the abdomen, and that is one more problem when there is an irreducible hernia. Then it becomes a real issue. Here, as Aham has rolled out, the most important use of CT in this patient is that what is adherent behind the scar, which is very, very important, because you will be very, very careful to tackle that problem. Here you can very well see practically there is no space between skin and the bowel at the places, even though you said it was pinchable. So that is another important. One more thing is intra-abdominal adhesions, as said, as the patient has been repeatedly operated. So you have to be careful about that, and it may be required, because the biggest problem is enterotomy in such cases, because then it may change your management and outcome of the patient. Khandelwal sir, please, would you like to add anything?
No, sir, very well summarized, sir.
Okay, Rajan bhai.
Yes. Nice discussion. I think nothing more to be added.
Okay. So, last slide.
Thank you.
Why do you call it complex?
Because skin changes are there. Skin is thin.
Skin is thin. That is the only problem. Any other problem?
Right. Peristalsis are seen, so bowel might be adherent at the.
Or at least it is part of the adherent, maybe with the hernial sac. Okay. Anything for a diagnosis part? I have one more question. You have written here. Have you written word incisional anywhere?
No.
I know. So it should be an incisional hernia.
Yes.
So why it is necessary to, what is difference between ventral hernia and incisional hernia? Is it same thing?
No, sir.
So what is difference?
Sir,
A very basic question I am asking.
Sir, when like umbilical hernia is also a ventral hernia, but there is no incision.
So what is difference? I want to ask you.
All incisional hernias are
that is dictum, but what is inside? So a hernia developing in a scar. That is the incisional hernia. Hernia present in a no previous surgery or a normal abdomen. That is a ventral hernia. So umbilical hernia, epigastric hernia, or even true ventral hernia are there. Yes. But incisional hernia, patient has been operated for them. So how does it make difference in the diagnosis part and management? How does it make difference that you say it is a ventral hernia and you say it is an incisional hernia? What difference does it make?
Which is easier to operate?
Sir, ventral hernia will be easier to operate because in incisional hernia, their planes are distorted and interbone pathology.
So in a ventral hernia, planes are preserved. So you can very well plan what surgery you want to do, whether you want to go sublay or whatever it is. Wherein incisional hernia, as the other people have said, you have to plan on your feet. Sometimes what you have planned pre-operative may not work because there might be a bad scar, there might be previous incisional hernia repair with mesh, without mesh, sutures may be there, and you may not find all plane as you wish. So incisional hernia is a total different pathology than ventral hernia. But your dictum is right. Almost all incisional hernia are ventral hernia, but all ventral hernia are not in. Suppose you have operated a case of umbilical hernia and it recurs. Can you call it incisional hernia?
No, sir. It will be recurrent umbilical hernia.
So what is difference there?
Sir, if a patient is previously operated like laparoscopic tubal ligation and then hernia develop, it is called incisional hernia, and again if recurrence occur, then it will be called recurrent incisional hernia. But if patient is previously operated for umbilical hernia and it recurrence, then it will be recurrent umbilical.
That is never. But why these two different nomenclature? So here the main important difference is that practically in a recurrent umbilical hernia, intra-abdominal pathology are less, and there is always likeliness there will be mesh in a recurrent hernia. But if you don't say recurrent, there may or may not be mesh. Patient has been operated for previously some other surgery. So it is very important to say the word recurrent incisional hernia, ventral hernia, recurrent umbilical hernia. That will give you the idea about it. Okay. So what do you propose to do now?
So
you have done CT, we have already discussed. You will have done a USG. Any other investigation you would like to do before going for a surgery? Surgery is must. There is no question about it. Suppose the patient said, I won't want to get operated. What will happen? What will be the outcome of this?
Sir,
in this patient, we are talking of this patient.
Yes, sir.
Do you think that it will get obstructed and strangulated?
No, sir. It will not get obstruct or strangulate, but there are interbowel adhesion which might lead to feature of obstruction.
Okay. But what is the most likely problem which is in
skin? Sir, skin might get a
ulceration or even intracutaneous fistula can be the outcome. For that also, a patient needs surgery apart from other and irreducibility because of the interbowel. But why it will not get obstructed according to you?
So defect is very large, so less chance of obstruction.
Okay. So, any other investigation you would like to do?
So pulmonary function test, serum protein albumin, other than routine blood investigation.
Why pulmonary function test?
Sir, if pulmonary function, if a patient is having any lung pathology, though hernia is reducible, but still we like to put patient on.
If there is no lung pathology, then so for others, I would like to add other faculties. Is it a pulmonary function test is mandatory in all such a large incisional hernia?
Looking at the CT scan, sir, I don't think I would go ahead and get a pulmonary function test unless and until there is a history of respiratory problem in the patient.
Yeah. Because that is unlikely that is why there is importance of Tanaka index and loss of domain. If there is no loss of domain and patient doesn't have any respiratory problem, pulmonary function test is not mandatory. Your opinion?
Sir, I agree with you and Dr. Khandelwal, but unfortunately, my anesthetist doesn't agree with us.
Same here. Same here. So we also need forced to do it all the time. But that's why I raised this question. It is not. But yes, if there is a possibility of loss of domain, there is a possibility that patient will definitely require ventilation immediately. Then there are indication. And yes, of course, as Pankaj has said, that if patient has a respiratory problem, it is mandatory. Any other investigations? I think that summarizes it. Anybody would like to add anything? Okay. So now what do you propose to do in this case?
Sir, you are muted. PRM, sir, you are muted.
Sorry. The point what I want to say now, what surgery you propose to do? That's what, and let other people ask. That's what I wanted to say.
Sir, open surgery by...
Because the first important question which will be discussed is the incision. Surgery is not a question. What is your preoperative proposal? What do you want to do in this case? Which incision and what type of surgery?
And Akshay, can I ask you any specific
Sir, I think these all other things has been already discussed.
एक मिनट राजन भाई खंडेलवाल साहब के कह રહ્યા છે एक જ મિનિટ રાजन ભાઈ.
Akshay, what preoperative preparation you would do in this patient which would be different from routine incisional hernias?
Sir, I will like to do bowel preparation by giving preoperatively peg leg, sir.
Fine.
Sir,
I am your opinion for repairs.
Do only one repair primarily, which is sublay right now. So that is what I would go with. Always attempt for a restopa with maximal usage of sac, but if that is not possible, then add a tar on top, macroporous mesh, and yeah, that is my go-to.
Yeah.
Regarding the macroporous, so now we have a good avenue for asking questions. Akshay,
yes.
What is all these things? Our conventional mesh, then we have a lightweight mesh, and now companies have come up with a medium weight mesh. Can you throw some light? And I would like him to at the end to give some comments.
Yes, sir. Ultra lightweight mesh is less than 35 gram per meter square. Lightweight is 35 to 50 gram per meter square. Medium weight is 50 to 80 gram per meter square, and heavy weight mesh are more than 80 gram per meter square. And sir, size of the pore, macroporous between 1 to 2 micron meter. Medium is, sir, 0.5 to 1 micrometer, and microporous is less than 0.5 micrometer, sir.
What is the importance? Where do you use what, and where you don't use which one?
Sir, we uses macroporous mesh because when granulation comes up between in the pores, they are not very much close to each other, and it will not give lumpy filling of mesh, and the retraction of the mesh is less in macroporous mesh.
Contraction.
Contraction of mesh.
So what is the difference in contraction? Sir has asked. What is the difference in the contraction of the two meshes?
Sir,
lightweight and conventional.
Microporous mesh, sir, contract by more than 40%, and macroporous 20%.
Right. So yes, please continue.
If a contraction is more, then chance of recurrence from the side of the mesh will increase.
Okay.
How do you decide which mesh you are going?
Which mesh? Yes. See, now the idea is not that always the lightweight meshes are good or macroporous are good. Different hernias need different hernias and the stature of the patient, the situation, the condition of the abdominal wall that decides what type of mesh you should use. Akshay, please throw some light.
I don't know, sir.
Ahem, your expert comments, please.
So essentially, all of the meshes that come, they are knitted. So for the PG students who are listening to us, if you go to a clothing store and if you look at different sweaters, all the sweaters are knitted, but they're all knitted differently. So some sweaters are a little heavier, some sweaters are a little wider, some seem to be very dense with fibers closely packed, and some others seem to have big holes in between them, very similar to those crocheted things our grandmothers used to knit for us earlier. So meshes are similar in the sense that the pattern of the weave is going to ensure that how much material goes into the mesh. So that determines the weight, how many grams per meter square, as Akshay properly pointed out. It also determines how widely spaced the fibers are. Every fiber in the body is going to function like a foreign body, so you will have a granuloma around the fiber. Now, if the fibers are very close to each other, like in heavyweight meshes, then these granulomas, they almost become a continuous plate, and the contraction that happens in the collagen after that affects the entire mesh in toto, and it contracts a lot more. But in contrast, when you have a macroporous mesh with the fibers widely spaced apart, the granulomas are also spaced away from each other. So when fibrosis occurs, it doesn't occur over the entire mesh as a single plate of sorts. So there is some ingrowth that happens, but you don't have a scar plate formation, which is good for you because the mesh doesn't contract as much. It stays as much as possible in the original position, size, shape that you had inserted in. The other good thing about macroporous meshes is that because the pores are large, white blood cells can actually go across the pores very easily. There is also easy movement of fluid across it. So if you want to insert a mesh into a contaminated or infected field, then you should only use a macroporous mesh. You should never go for heavyweight or microporous meshes because the chance of that mesh needing explantation because of an infection is much higher. Macroporous meshes tolerate infections well, their performance is better, and you can salvage these meshes much, much better. To give you an example, I had a TAR, I think this was in August or September. Patient had an enterotomy during really bad adhesiolysis, also had a VP shunt in C2 that I had to manage. Large hernia, 12, 13 centimeters across, eccentric. I landed up using a soft mesh in the patient for all of these high risk of infections that she had. She eventually did develop a low grade mesh infection, but I was able to wax that area and I got away with it without removing the mesh. The same thing if I would have used a heavyweight mesh, I would have very likely needed a repeat surgery, pull the entire mesh out. That's a problem. Akshay, a little point of correction for you. There is some literature that says a microporous mesh is with a pore size of less than 100 microns, but that has now been removed. Recent literature goes and states macroporous has a threshold of 3 mm. See, because microns you require a microscope to see. 3 mm you can make out with a standard ruler that is available to us. So the general rule right now to call a mesh macroporous if the large pores are 3 mm or wider. It's not in microns anymore, 3 millimeters.
Yes,
I hope that's clear.
Yes.
What about the recurrence rates that because medium weight meshes have come up? Ahem, your opinion, and Dr. Khanel Salb, your opinion?
Absolutely, sir. So this is like Goldilocks, and there are compromises on every side. We started off by using very heavy meshes, but we had a high risk of infection, very high chance of foreign body sensations, chronic pain. And then we went very light in the early 2000s, less than 30 grams per meter square at times. And then we had a lot of meshes breaking, a lot of recurrences, these problems. So now midweight meshes, which are somewhere around 45 to 75 grams, they'll end up having a good long-term recurrence profile. That is, we've not found them to fracture easily. Recurrence rates are reasonably constant in TAR at about 4 to 5%, which is okay in my opinion. They don't lead to a lot of contraction or foreign body sensation. Another interesting thing is polypropylene meshes have a lesser incidence of foreign body sensation than polyester. So all of the meshes that we land up using right now are macroporous mid-weight polypropylene meshes. The only exception to the rule becomes if you have a very large hernia with loss of domain where you feel the fascia is not coming close together, or the patient has a recurrent hernia or a hernia at an eccentric site, say subcostal, lumbar, subxiphoid, something to that effect. In that situation, there is still value for a heavyweight mesh, uh, especially in bridging repairs or when the patient has a high likelihood for bridging, because a midweight or a lightweight mesh is going to tear apart if it is not covered by fascia eventually. These patients have a diastatic sort of picture that comes in, which is prevented by using heavyweight meshes. So when I start my cases, I usually have 2 heavy and 2 midweight meshes that are available with me at all times. I take an intra-op decision as to which one I want to eventually open. Gives me that flexibility.
Dr. Khandelwal, sir?
I think very well summarized by Ahem. I would normally go in a very similar manner. Most of the time, macroporous meshes to be used, and heavyweight meshes I tend to use only when I have patients who have had multiple recurrences and have been operated in the past. Uh, Otherwise, I would most of the time stick to the macroporous meshes.
I have a question. Sorry.
Comments, yes, sir.
So I have a question. Fine, it's a very well summarized. The point he has mentioned, I think PGs understood or not, I don't know what he meant by bridging mesh. Akshay?
Sir, bridging mesh are a type of inlay mesh plastic. When we are not able to close the anterior sheath, we replace the gap by another mesh and suture it with
there will
the
be
sheath.
lot of tension on those meshes, so it is better to use a microporous meshes at that particular, or heavy meshes, which we call it. Otherwise, that mesh is likely to break or cause the problem. So that is the point. Inside heavy or a lightweight, on that side. There is one more question. What is the role of intra-abdominal sandwich type of meshes, or that what we call physio, or that?
Sir,
is there any role of those meshes?
Sir, in physio mesh, the inner layer is of polyglectin, and which is covered by polyglycapron, sir.
No, that is what. But what is the use? Can it be used in a very large incisional hernia as a part of repair? Because that companies are promoting them now.
Yes, sir. But sir, recurrence rate are more in.
No, because the one point you should understand, it's extremely rare to use them. In which desperate condition you may need to use it.
Sir, if we are planning to put intraperitoneal, then
it is not decided pre-operatively. Remember this point. And what is your take on this, Pankaj Khandelwal, sir?
Yes, sir. For open incisional hernias, we would very rarely be using these dual meshes. Now, the only circumstance wherein I would think about using it would be when I'm not able to get a repair of the posterior sheath. If that's not feasible, and I am worried about the exposure of the proline material to it, and if there's a significant loss, for all practical purposes, I haven't come across those type of situations yet. But if that is the scenario, I might think about using a dual mesh, place it intraperitoneally, and then go for the closure.
Yeah, because to prevent the recurrence, and particularly it is a usual indicator when the patient has already been tried with all kind of repairs. Usually recurrent hernia, when even TAR might have been tried, multiple meshes has been put. To get the various plane is practically impossible. In those cases, to re-put the mesh in the wall will become very difficult. So that is a desperate measure in a rare circumstances. But it always comes with a that you cannot have only mesh, because you need to have a bridge mesh at the anterior. Otherwise, that will bulge out and will create a problem. So that is always used along with the bridging mesh. Aham, what is your opinion about that?
No, sir, I completely agree with what you and Dr. Khandelwal just said. Nothing much to add on that.
Sir,
yeah, somebody.
I have been encounter with using the intraperitoneal, what you call is a proceed or whatever the mess. Only once only. The patient is having a colostomy site, huge hernia, and main incisional site hernia. In that case, we have done is we have put a intraperitoneal mesh at the site of the colostomy after reduction of the sac and everything, and in the centrally we have closed with the regular mass of the soft roll in soft mass. So the role is that if there is a multiple huge hernia in the lateral wall, then and you can be able to dissect it well, there is a clear cut role of a this kind of a mass. Otherwise, for a ventral hernia, no, that is not. I don't feel there is a much more use.
Okay, very well said. Akshay, considering all this mesh availability and that, you are operating this case as the CT suggests it is transverse colon. While dissecting, you have opened the transverse colon. What will you do?
Sir, I will primarily repair the transverse colon, and sir, I would not like to put the mesh.
Then how will you close it?
Sir, I will like to do, sir, laparoscopy can be done, sir, in this.
Pardon, I don't get it. What do you say?
Sir, as we have repaired the transverse colon, there might be chance of leak. So if we put the mesh, it might get infected, sir.
So you will not put a mesh. So what will you do then? If you don't put a mesh, how will you close such a large incisional hernia?
Sir, secondary close. I will plan for secondary close.
What secondary closure? What kind of secondary?
Akshay, you have already given Akshay.
Yes, sir.
You have already given bowel wash. Your bowels are already prepared, and your possible enterotomy of colon would be hardly 1 centimeter, which you will require two stitches, 3 stitches to close. And what are the chances of that closure give way?
Sir, less chance. So mesh can be put.
So mesh can be put.
It cannot be like that. If you feel you put a mesh, if you don't feel you don't put a mesh. What is the?
It is not that.
Yeah, it's not like that. Hemant, continue, please.
Yes. So what are your decision-making criteria if the enterotomy is done?
Sir, if there is no spillage, sir, if there is no spillage, then mesh can be put. Right.
So what are the classification of wound in such cases? You know the basic thing, classification.
Yes, sir. So clean
So
wound.
almost all circumstances, if you are a fair surgeon, this will become a clean contaminated wound.
Yes, sir.
Right? So
Yes.
what is your take? Forget about this patient, any patient. What is your take if it is a clean contaminated wound? A patient who has as Rajan Bhai has said, patient has a colostomy. You want to do a parastomal hernia repair with closure of colostomy. It amounts to same thing. So will you put a mesh or not?
Yes, sir. We'll put mesh.
So what is your take? Pankaj, please.
So as you rightly said, it would depend on the amount of the contamination. Now, if I have a prepared bowel, and while separating the colon, if there is a very small puncture into the colon, then and I could repair it without any spillage, I would still go ahead and place a mesh in this type of a scenario. Only the problem would be if there is a leak defect, if there is a contamination, then I would not want to place in a mesh, repair it, come out again, and then plan the misplacement of the mesh after either a few days when everything is fine or at a later on stage.
So here it is a really complex problem, we can understand. But it has been now said that you can put a mesh in clean contaminated wound. So at the base, this will be a really clean contaminated wound. If you don't put a mesh, patient will become more messy. There are certain riders. You do not do very elaborate dissection after that. Try to put a mesh with a limited dissection. That is the one thing. So if you can put a retrorectus mesh or as such as topaz type of repair, it would be good enough. If you do try a plan, a TAR in such cases, which may not be required in this patient, if you plan that, it will become very chances of infection, and that is why that. But for my take, I would always put a mesh in such cases, unless it is very badly contaminated wound when there is it looks like a fecal floating in feces, and that's a different thing. But in a planned way, you have already prepared the bowel, so mesh should be put. Where and how to put, it is a per operative decision.
Yes, sir, completely agree with that. I think also it depends on when the enterotomy has occurred.
Yeah.
Akshay, if you're doing the case and if you have started with a small limited laparotomy away from the hernia and you're moving towards the hernia, you have a small colotomy or an enterotomy, then there is always an option to quickly suture that up with PDS, abandon the repair at that point, close the fascia and the skin on top, and then come back to fight another day. Because it's happened early in the case. But if you've, progressed quite further down in the case, the full abdomen is open, there is no way for you to close the fascia and skin on top without a burst abdomen in the post-operative period. So you're fairly committed to doing something for the patient.
Yes.
So now your strategy becomes, how do I ensure that the fascia closes, that I deploy a mesh as safely as possible and reduce the chance of infection? The pehla thing, that has been said several times over is the bowel will usually be prepared to some degree beforehand. So you quickly suture up that enterotomy with a PDS. And then, of course, we use power of prayer to ensure that it does not open up in the post-operative period. Then beyond that, you need to perform whatever dissection, or sometimes you do land up committing to a TAR as well because big hernias don't close. So ensure at the end of posterior closure you use something called an antibiotic irrigation device that is available with orthopedics in most cases. So it is a pulsed irrigation lavage system. There's an antibiotic solution with metronidazole and clindamycin that is primarily utilized. The pulsed lavage displaces the bacteria from the retromuscular space and immediately suctions out whatever little effluent that is there. The caveat here is that sometimes it breaks open your sutures and can cause small peritoneal rents. So you need to check for that completely. Then you reduce your chance of mesh infection by placing a lightweight or a mid-weight macroporous mesh, and you leave some drains in situ to take care of any little amount of lipomatous collection, that usually happens in these cases when you're dissecting in the retroperitoneum. Remove the drains in a couple of days and give appropriate antibiotics with some anaerobic cover to these guys. Most of these patients, especially since we are talking about sublay repairs, they do well because the muscle is well vascularized. This is not like when you do an onlay repair where the fat does not have good vascular supply, allows the mesh to stay infected. So there are a few things you can do at the time of surgery to improve your outcomes, but that is only when you're absolutely committed to the case and there is no way back. If it happens early enough, then you can pull out and come back, because an enterotomy is the single most important factor that increases not just the chance of post-op SSI and recurrence, but also post-op systemic complications and mortality. So
Yes.
we shouldn't take it lightly, but as Modi sir said, now evidence is towards the use of light and mid-weight polypropylene in these cases. We used to discuss biologicals very heavily a few years ago, but obviously cost has played a major factor. And last year, I think a few meta-analyses have come out saying that biologicals may not be as great as they were pitched to be. Maybe people lobbied for it a lot more because there were financial gains. So lightweight meshes will have some value going ahead.
Yeah. Yes. Excellent. Perfectly said. So that is the point you should understand. Don't afraid to put a mesh. Yes. Because the other way is not a proper way. There is one more question. Would you put an intra-abdominal drain? Because we do so many stoma closure with incisional hernia. It is practically same thing, and we always put a mesh. So not putting mesh is a rarely an option, unless, as I have said, particularly if it is the emergency or we have really made a mesh of our intestines. Otherwise, you can always put a mesh with a barrier in between. Try to close the peritoneum or sit posteriorly and put a in between mesh. That would be the best. Some you also used to recommend that if this occur or it is not more than one enterotomy, go for a only mesh plastic. What do you say about that? There's a one question, and second is the intra-abdominal drain. When will you put an intra-abdominal drain? I'm not talking of wall drain.
Sir, if we have repaired the enterotomy, then we can put intra-abdominal.
We can. You in exam don't say that. We can put is a very vague answer. You should be whether you will put or not put. That is what you need to, all of PG should understand. There is nothing like a 50-50 answer. What is meaning of you can put means if I want, I can put. If you want, you want. What is your opinion? And that is what the point of discussion. A drain can always be put. So it should be, will you put or not?
No, sir, I will not.
Why?
So it is clean contaminated wound and it is a iatrogenic perforation, so chance of a leak is less.
You are going second extreme now. First place, you are not ready to put a mesh, and now you are not ready to put a drain. So always in doubt, put a drain in such cases because it may improve the healthy environment and patient can have that. Unless it is a small bowel, very pinpoint perforation or something like that. Including myself, sometimes we do not put a drain in certain cases, but most of the time it is preferable to put an intra-abdominal drain, particularly when you are putting a mesh in such cases, if enterotomy has occurred. Anybody would like to comment on that, please? Because it's a point of discussion.
Dr. Khandelwal?
That's a fair point, sir. But that being said, now I feel it is a little challenging to put abdominal drains after a TAR.
Yeah.
Because there is always a chance that the drain may back something on the way out. So I have shifted to using Jackson Pratt drains. In TAR cases with some extra suturing next to the drains to ensure that the aperture doesn't suddenly split open when the drain is being pulled. It's a little bit of an issue.
Yeah, that's the problem because they are always worried that it will cause the site of a next hernia or can create a problem. So that is the point of discussion. There are people who put it, there are people who do not put it. Yeah.
And for the drain again, sir, what I have also done over the years is very rarely now I would put the drain because most of the time I've seen that if there is actually a leak, the drain doesn't show us. Rather, the tachycardia and the fever and the increase in counts are better parameters.
Yeah.
So, quite a good number of these cases we don't keep drain anymore.
Yeah. Yes, that's because the both school are there. Yes. So you may or may not put a drain, depends upon the local condition, I would suggest rather. And there is always a disadvantage of putting a drain in certain cases. But we do put in some cases if the enterotomy is there and like that, but it's up to you. So then the next question is, what is the role of wall drain, negative drain? Why do we put that drain?
Sir, negative drain is put if we have raised the flap too much. Large, if you have raised the flap too much, then to keep the negative pressure, it will keep the helps in healing of flaps, sir, and prevent seroma formation.
So is the seroma good or bad?
Seroma is good, sir. It's
there is a tendency people Yes, somebody was saying that. Akshay, you were saying something?
If a large amount of seroma is formed, then it hinders the blood supply to the skin. But if a less amount of seroma is good for healing.
So I would rather say, what I would say is that it depends upon where you are putting the mesh. See, nowadays we don't put in an onlay mesh, but I think for an onlay mesh, drain is a must because you are creating a subcutaneous plane. If you are putting the routine preperitoneal meshplasty or a retrorectus meshplasty, it depends upon how good the hemostasis is. Otherwise, because there is not much space for the mesh to go. Below there is peritoneum and the posterior sheath. Anteriorly there is rectus muscle and all the muscles of the abdomen. So unless and until if you are very sure about the hemostasis, you may or may not put the drain if it is a preperitoneal meshplasty. But if you are talking about sublay, I mean that is a onlay meshplasty, I think drain is a must. Pankaj bhai?
I think it should be all right. Anybody would like to add anything? Otherwise, fine. It's all right.
I think it's good, sir. We discussed quite a bit.
Okay. That's fine. I think we should sort of. Thank you. Thank you very much, Dr. Aham, Dr. Pankaj. Thank you for joining Rajan Bhai, Hemant, and all our participants. Thank you very much.
Thank you, sir, for involving us, and thank you, Akshay, for presenting today.
Okay. Thank you very much.
Thank you, sir, for the invitation. Thank you.
Thank you, sir.
Thank you very much, sir. Yep.